Number one, superior epigastric artery, and number two, musculophrenic artery. Is that clear? Musculophrenic artery, it gives anterior intercostal arteries for the spaces 7, 8, 9. So three spaces. Space number 7, space number 8, and space number 9. They get their blood supply from the musculophrenic artery. Clear? When we'll do in detail, then we'll talk. And these two arteries are the terminal branches. The superior epigastric and musculophrenic are the terminal branches of internal arteries. Is that clear? Musculophrenic and superior epigastric. Clear? Now, who are the arteries of posterior intercostal space? Who gives branches in the posterior intercostal space? Thoracic aorta. In each space, it gives branches, and these branches from anterior and posterior, they meet. So there we had a pattern of circulation in each intercostal space. The main supply obviously comes from thoracic aorta, right? But this circulation is very important, and there are certain situations. Probably I'll discuss this point in detail on Thursday. Come prepared with these things, where I'll be talking about the vessels of the thoracic cavity, and this is the coarctation of aorta is one of the conditions where we have problems, and the blockade of the superior inferior vena cava, and there we will talk about the collateral channels, collateral circulations, and in these individuals how the body demand is being fulfilled and how the blood supply can be maintained to the upper part and the lower part of the body. Is that clear? Yes. Now, there is a breast, nipple, and then this is the axillary tail. It extends into the axilla. So when we are treating malignancies of the breast, we have to go for axillary sampling and all that. Even the part of the breast extend into the axilla, and that you will learn when you will be in higher grades. Now, I'll start talking the muscles which brings about respiratory movements. We had the primary muscles and we had the secondary muscles. Secondary muscles are also known as the accessory muscles. Abdulaziz, what's the problem? Why are they hitting on you or you're hitting on them? Tell me. Something wrong? So now talk about these. Are you settled, Abdulaziz? No. Thank you. So let's start putting up. When we, like you are sitting here, everyone is breathing, but nobody notices. But sometimes we breathe like, is it different? That is forced inspiration or forced type of respiratory movement. And now at the moment you are breathing quietly. So for the quiet respiratory movements, we are using our primary muscles. And for the forced type of movements, we are using our accessory muscles. When we are using our accessory muscles, then we got the time when we are climbing uphill. Once we are after a big jog, after a big running, we have like that, and after exercise or some dog was after you and then dog is gone somewhere. Then you have that status. So let's take the muscles who bring about the quiet respiratory movements, and we had the intercostal muscles, and there we are. What direction says? Who's this guy? External intercostal muscles. And who's this one? Opposite to that. Internal. So we had external and internal intercostal muscles. Who's this guy? Innermost. Guys, this innermost has different names. Behind the sternum, we call it transversus thoracis. Then we had innermost. On the posterior side, we had subcostal. So there are so many names for this third layer. And this third layer is not complete. External intercostal, internal intercostal, they are complete layers. Now, who's this guy? Diaphragm. Is that clear? And the nerve supply for the diaphragm is C3, 4 and 5. Guys, be good with diaphragm and phrenic nerve. They are very, very, very dear to us. So you know what is the meaning of dear. It's not ghazal dear. So now let's take both the muscle used for the quiet breathing and the muscle used for forceful breathing. So we know it. External, up till diaphragm we did it. Now, the accessory muscles of respiratory movement used for forced respiration, and we had number 1 on the list, splenius. So anterior and medius. Then we had sternocleidomastoid, pec major, pec minor. Who's this? Abdominal muscle, who are they? So there's a list. So these muscles are, those who are on this side, these are the accessory muscles, and these are the main muscles. Right? With the red, the accessory muscles. Is that clear? Yes, Pali.
Why are the fibers of internal and external because they're going in the same direction? Did you say
they're not going in the same direction. Look, they are coming down, they are coming up. They are going up. They are opposite to each other. I cannot show you with the arrows.
And they will make X.
If I bring them here, you will not see, you will find only X, and you will not anticipate what happens. Is that clear so far? Yes.
The innermost intercostal muscles are found in every intercostal space. They are.
My dear, innermost intercostal layer is differently named at different places. It's not one complete sheet. External intercostal is a complete wrap. Internal intercostal is a complete wrap. But innermost layer in the anterior part it is called as transversus thoracis. Then it's called innermost intercostal. Then it's called subcostal. Then it's called costalis. Right? So there are patchwork. There are patches of these muscles. Vilela. Mushkila? Clear this one? Now, I make a cut here to understand an intercostal space. I make a cut here, and with this cut, I'll go here. So there you are looking, guys. Now these 3-4 slides, they are very important, and you need to be very focused now. So now we are exploring intercostal space, and we are looking for, because these slides are well connected, so we need to go in detail. So we are looking at a rib above and a rib below, right? So rib above and rib below, each rib has a superior border and an inferior border. Clear? And now we talk about there was a notch, and we said that this notch contains neurovascular bundle. When we use the word neurovascular bundle, the word neuro goes for nerve and vascular means artery and vein. So we have this costal groove will be showing you that. And this red line is demarcating the skin. There we have the superficial fascia and the deep fascia. And there we had external intercostal muscle layer. And this guy, the one who runs in between, that is the internal intercostal muscle. Clear? And now there I have my neurovascular bundle. They are arranged in a fixed pattern. First we have the vein, then we have artery, and then we have nerve. So vein. Right? So they are arranged like this. And this is their main side. There we have the main vessels. They give their collaterals, and we can find the collaterals going here also. It's not shown in the image yet. and this is the innermost layer. And this innermost layer is being labeled differently at different places. So this innermost muscle layer, and now who's this? Endothoracic fascia, loose alveolar tissue, and this blue thing is my parietal pleura, and this is the visceral pleura. So this is typically something about an intercostal space. Is that clear?
Yes.
The space between the two ribs is known as intercostal space, but it contains 1, 2, 3 muscles, and it contains this neurovascular bundle and their collateral vessels. Hamza, it was better you were sleeping. Why don't you sleep again? You're talking with Saeed. Saeed is busy. Hisham, Mushkila. Now this, what is this? Now here in this image, you are looking at each intercostal space and look at the arteries, veins. Mohanad, why are you whistling? You are looking at the arteries, veins and nerves, and you can see there internal thoracic artery, it sends anterior intercostal artery, and from the aorta you are looking at the posterior intercostal artery. Same goes with the veins, and there are nerves for each space, and there is a mesh of these neurovascular bundle which runs all across these intercostal spaces. Is that clear? We'll talk about in more detail with the same image on Thursday. Now this is a typical intercostal space. Again a revisit what we have talked right now. Rib above, there is a costal groove, inferior border, superior border. Who's this? External intercostal, internal intercostal. Right? So this is how, Ani, man, this is something which will really make difference. And when question comes, we'll see big number of failures. And you started talking, what for? I'm not looking at you guys. I have no problem. I can, trust me, I can bring images like this, and I can talk and I can finish. This is this, this is this, this is this. Why I'm bothering for that much? Then you're gonna lose, you're gonna cry off. I will say I have explained everything. It's written here everything. Why I'm going in details? So again, so we have this neurovascular bundle, and now this is the innermost layer, how it covers it, and you are looking at the innermost, and this is what? This is in front, internal intercostal layer. Is that clear? So this is how we have a typical intercostal space. And now these neurovascular bundle, they send their collaterals. Can you see them? The collateral branches. And then these ones, they come down and we can find them here. Yes?
Why is the nerve is outside the costal margin? Does that make it susceptible?
My dear, it's not outside, it's a drawing. It's a hand drawing. Otherwise everything is in shield. And remember, it's not covering everything. There is something, and once we are doing it, once we are doing some procedure, we have to save them. Right?
Is there any sheet around the bundles, like a sheet?
Not really. Not any problem. And remember, any sheet, usually, the nerve is always outside. You know why? Why the nerve is outside the sheets, mostly in axillary sheath, femoral sheath. Yes, to minimize the compression. And vein is also the sheath where it covers the sheath, it is always weak. The vein, when it is covered by the sheath, that part of the sheath is always weak, because veins needs to dilate. Once we have venous return, and venous return in big in quantity, so at that time veins need to engorge. Arteries, they pulsate, they can accommodate, but veins, they engorge. And there we had sort of, but Yusuf, Stop. So these collateral branches are very important. Where? When we are doing procedures, because we understand, and these are well protected. The main neurovascular bundle is well protected, but these collateral branches, they are at risk once we are performing certain procedures. What are these procedures? We may need to block a nerve. We may need to drain hemothorax. We may need to drain a pneumothorax. We may need to drain a pyothorax. What are these terms? The word hemothorax means once there is a blood in the pleural cavity, pus in the pleural cavity, air in the pleural cavity. So all these words, all these things, they need intervention. And interventions should be beneficial and useful for the patients. They should not be harmful for the patients. To bring about all that, we need to be careful, and how we can access that we are looking in our next slide. So we have to be very careful in specific when we are approaching these spaces. We should give maximum benefit to our patients. How we bring that? The question is how to access an intercostal space. Now let's look in that. We know about rib above, rib below, external intercostal muscle, internal intercostal muscle. There we are looking at the innermost layer. There we have neurovascular bundle above, neurovascular bundle, like each group contains this neurovascular bundle. I'll show you now the collaterals here also. This is the intercostal neurovascular bundle. And there we have, what is that? Endothoracic fascia, parietal pleura. But what happened to this visceral pleura? So there is a swelling. There is something, and there is some pus. Once we have pus in the pleural cavity, that is known as empyema thoracis. Empyema, collection of pus in the pleural cavity. Now this patient will not come to you and talking that, doctor, I have pus in my visceral and pleural layer of my pleura. Can you do something for me? He will come to you with a fever, which is not responding to the normal treatment. He will in a severe pain. He is in distress. He is sweating. He might be having blood pressure, and he is in a very bad situation. He cannot continue his work or studies, and that person needs some special interventions, and he needs to be dealt nicely. So now this pus, this fluid, this stuff has to be drained. Remember, anywhere in our body if we have pus, the only treatment is to drain it out. There is no antibiotic, there is no any medication which can destroy the pus. Only one solution, you should go in and you have to drain this pus out. If you don't drain the pus out, patient will never get better. So how to get in any intercostal space, we have to go very safely. So what is the safest place? We have to go above to this lower, this lower rib, its upper border. But we have to be careful. There is also, we have the location of neurovascular bundle. So we can insert the needle like this. We are going above, we are going in the lower part, but we are going obliquely upwards. So we are saving what? We are saving these collaterals. These are the collaterals of this main neurovascular bundle. So a needle should be directed. They should be going in the lower part of the space, and needle should be directed upwards, obliquely upwards. And that's the safest method by which we can access any intercostal space. Now this discussion, it goes further. And now, to insert a chest drain or a chest tube. So why we insert a chest tube? What is the benefit?
Remove the
Drain.
Remember,
fluid builds up in the pleural
when
cavity.
someone has air, we call it pneumothorax. When someone has blood, we call it hemothorax. When someone has some fluid, we call it hydrothorax. When someone has pus, we call it pyothorax. When someone has chyle, we call it